I self-introduce myself. I want to tell you a story why I started learning PUK or ocular inflammation myself. When I was doing fellowship in '92 with Dr. Rao, at that time I had a patient from Odisha, a young lady with rheumatoid arthritis with corneal perforation, and she was sent for a PK. When we examined her, she had active perforation with hypopyon, with swollen joint, with 135 ESR. So when Dr. Rao said, please take this lady to NIMS, rheumatologist, and if we don't treat, she may die of vasculitis. So I took to NIMS. There is a doctor, very big HOD, and he saw and he did all investigation. He says, nothing active systemically. She doesn't have an RA. Only ESR is raised. And so he said, nothing, I can't give systemic treatment. So I bring back to Dr. Rao, and he gets very angry. He said, you have no idea, this lady will die. And I said, but he refused that there is nothing systemically. So then sent me back that you pull out the literature and then throw these letters on the professor's face. I said, sir, I can't do, I'm a very small fellow, I can't do these things. I went again, showed him the literature. He said, if you have the literature, why don't you treat? We can't treat because it's not systemically active. So in that process, what I realized on that day, that both the doctors have right intention, but Dr. Rao did not know how to treat systemically, and the rheumatologist did not know ophthalmological manifestation is as equally important. So sometimes we have to take little extra step. Now, of course, the situation is slightly better in our country, that there are more rheumatologists, and if you can find good one who can listen to you, is very helpful. Can I have my slides, please?
What was the final outcome?
Final outcome, I mean, we did not give, only we gave a systemic steroids, and we did treat ourselves. Rheumatologists did not. Another example, when I came back from US in '98, there was a patient of Wagner's. I sent to a rheumatologist. He called me, he says, Dr. साहब, ये तो मैंने किताब में पढ़ा है, पेशेंट कभी नहीं देखा, तो मैं क्या करूँ इसका? मैंने कहा, सर आप ना इसका सिस्टमिक देख लो, बाकी मैं संभाल लूँगा. तो उनको सिस्टमिक ट्रीटमेंट I started doing myself. And that's why that if you want to treat these patients, and they are predominantly eye patient, I think it's the responsibility of ophthalmologist, or find a good solution to that. All right, I'll talk surgical management. So this is I said you this in the introduction slide. So this was, the patient gave a history of some another surgery, details were not known, and we did a patch graft, and we sent the tissue which was excised, and this is what the outcome was. Not only this is what happened. After the surgery, it started going downhill, and essentially then we lost that eye. So now sometimes you may feel that maybe you if you did not do anything, probably you would have not caused this, but we did save his life, because he had a infiltrating carcinoma, and which has the potential to not only spread to the eye, it could have gone to the rest of the body also. This was the histopathological evidence. This is a patient I managed in 2001, had a history of pteresium surgery. This gentleman comes from Rajasthan, and when you see this, immediately you will get scared that yes, this is a perforation, there is a uveal show, I must do immediately something about it. But there is remarkable if things you've noticed. They are metastatic lesions, the yellowish infiltrates, and it's very neat and clean. There is no discharge. So there is no question that it is infectious. It's not possible that it is infectious, right? So now here it's very important to understand, if I do a patch graft now first, then the same process, inflammatory process, will melt that graft also. So what was the key? To treat the patient systemically after doing a basic investigation, and then do a patch graft. So I treated him with the IV cyclophosphamide, IV methylprednisolone, then oral for 6 weeks, and then went ahead and did a scleral patch graft. And this continued the treatment for next 1 year, and followed it very closely every 2 to 3 months with the CBC and LFT RBS. And later he underwent a cataract surgery in the same eye, and the vision improved. Best corrected vision was 20/25 in that eye. So it's not that you cannot salvage these kind of eyes. This is a patient which was diagnosed as Moran's ulcer for several years and treated as it is. And when it presented to us, we suspected that it doesn't look like a Moran's ulcer. You agree that now looking at the pictures that it does not fulfill Watson's criteria. Clinically it doesn't look like a PUK. So it was a carcinoma, and he underwent a orbital, EVCRC and after exenteration. This is a standard patient with rheumatoid arthritis with small peripheral perforation with systemic treatment, underwent the patch graft and healed very well. Another interesting case, a 15-year-old girl referred from J&K. She had consulted 5 other doctors. She was diagnosed as VKC, received a supratarsal steroid injection, and there was a tarsal necrosis. If you see here, there is a tarsal necrosis on the site where injection was given. And for me, this was very remarkable. I never seen this kind of presentation. She also had a elevated mass, a peripheral ulceration, AC inflammation, KPs. I had no idea what it is. Therefore, I removed that mass, put TABCL, put amniotic membrane on top, took AC tap, and also sent the tissue for histopathology, and suspecting that there is something weird. And what it turns out to be? This turns out to be a Mycobacterium tuberculosis. This was a conjunctival Mycobacterium tuberculosis when she was treated with systemic ATT for 8 months, and she recovered completely. This is a very instructive patient. I encountered very early in my career at LVP. This was a Moran's ulcer or some sort of PUK, and one of my colleagues did a patch graft, and we did not immunosuppress because thinking that it doesn't look very aggressive. And within 4 or 5 weeks, the patient comes back with this kind of inflammation. The patch graft is gone, and it is clearly that the immune process has eaten away the graft completely, and now at this stage giving him IV methylprednisolone and all that not very beneficial because most of the cornea is destroyed anyway. I'll skip this part because we have seen enough of it. So the fundamental treatment for surgical treatment for is the conjunctival resection TABCL, and if you have the histopathology or immunopathology, please do the histopathology and immunopathology of those tissues, and if you have a perforation, do a patch graft, but these patients would need some sort of immunosuppression, immunomodulation. These are the examples of patch graft. On the lower side, this is a rabbit model of a corneal scar or neurotrophic keratitis which we are developing, and it's a liquid cornea. And what I am thinking that if I have to do a patch graft, once I have this material, after removing this diseased tissue, I can just use this liquid cornea and create that mass, and since it does not have keratocyte, it will not be subjected to immune mediated inflammation. So I am thinking that instead of doing a complicated patch graft, in future I may be able to treat this with the liquid cornea with mesenchymal cells or with exosomes derived from the mesenchymal cells. This is another way of doing the patch graft, that there is a perforation, not only central perforation, then lamellar. So centrally we will seal the perforation first and then do a patch graft. And this was shown by Dahlia as well about how to do a patch graft. And if you are a corneal specialist, doing the patch graft probably little more complicated than PK, but it is doable. So you do lamellar dissection depending on the thinning that you notice. These are very small number of patients that we have looked at the patch graft in LVP at that time, and if you use systemic immunosuppression, the outcome of these surgeries is not that bad. This is a patient of Moran's ulcer. Now this is this is the same video. I will skip. This is the same video that I showed you for the tuberculosis, but this is just showing the technique of conjunctival resection. Conjunctival resection, you want to do at least 1 clock hour on either side of the lesion, and you want to cover the healthy part as well, one clock hour. This is a Moran's ulcer where you have a central island remaining. So it was a pediatric patient. So what I did was I removed the central island, and then you don't need systemic immunosuppression because whole of the stroma is destroyed. The other video I am showing you, if I have this patient and if I have that liquid cornea, I will not do this procedure. I will remove it and fill with the liquid cornea, and hopefully will reconstitute the stroma. Then in around 2010-2011, we started doing patient with bilateral Moran's who have failed several PKs, Boston type 1 keratoprosthesis. Because in these patients, the PKP really does not work well. And these are the example of patients with the bilateral limbal stem cell deficiency due to Moran's ulcer and VKC. And this is a one patient who underwent the Boston type 1 Kpro and received systemic methotrexate, and this worked for several years. Then there was always a question, can the cataract surgery be safe? Because in the literature, it's very commonly believed that if you do surgery, it can initiate the Moran's ulcer reactivation. I don't think that is really true, and therefore I have been doing the cataract surgery in Moran's ulcer from very early on. This was the case report in JCRS in 2005, where we've done 2 or 3 patients, and this is an example of a ECC in a patient with the healed Moran's ulcer. This is a more recent example of a healed Moran's ulcer, and I'm doing a phacoemulsification. So the surgical technique, or it really does not matter whether you do scleral, like I do prefer all cataract surgeries, posterior limbal incision, don't need to be clear corneal or avoiding cornea. I don't think it makes any difference. After that, we have published a large series of patients of treatment of cataract surgery in Moran's ulcer, and it was published in Cornea, around 22 patients, 26 eyes. The technique wise, I use where possible phaco is the first choice if I can do it. If not, then ECC or SICS. You must have seen the IOL was very different. It's the IOL that I had designed with the IOCare. When you have pupil which is damaged, especially in uveitis patient and other conditions, so I designed an IOL with 3 millimeter pupil. Rest of this PMMA is pigmented, so there is no too much light going into the eye. And these patients have done well post cataract surgery. This is another example of a patient. His half the cornea is remaining, but still from that he is able to see 20/50. We cannot overemphasize the value of immune modulation. It's very, very important that we either use ourselves or we collaborate with a rheumatologist, hemato-oncologist, immunologist, whosoever that you can find. And these are some of the step-ladder algorithm published in the literature. And there is a very large study published from one from Arvind, one from China, and another from LVP of Moran's ulcer. The treatment, the outcomes are really well reported, and we understand this disease much better now. This is a pediatric Moran's ulcer that we had published in 2012 in BJO, the management, and we use systemic treatment there also, because in pediatric you use the immunomodulation in the doses that is prescribed for them. So in summary, the PUK, immune-mediated PUK is not very uncommon, and the treatment part, medical part comes the first, and then the surgical part, and where relevant. We must remember that a planned PK does not work. If you have to do a patch graft or if you have to do a therapeutic PK4 perforation, that may be different. If in bilateral end stage LSCD due to Moran's, Boston type 1 is a good option. Cataract surgery is quite safe and effective in these patients. Thank you very much. This is the, if you want to scan the handout which Isha showed on her presentation. So those of you who came later would like to download the handout which is prepared very nicely, and we'll be happy to take more questions if there are any.
Thank you very much, Dr. Sangwan, for a wonderful talk on surgical management. So all of you who want to know more about how Dr. Sangwan works and how his mind works, I'm sure a lot of you will know that now his biography is out. It is called Unbound. It is available online and offline. So you can find it on Amazon, and I highly recommend that all of you should read this.
Thank you, Jayesh. ले लो picture ले रहा है.
Sangwan sir, thank you very much for beautiful insight of this PUK management. I have few questions about this. First, the majority of the PUK cases associated with rheumatoid arthritis especially, we see that there is a severe dry.
Yes.
It includes the filamentary keratitis also.
Yes.
So what you recommend in that case of filamentary keratitis about the topical medication especially? I want to know about what is the role of the vitamin C and what is the role of N-acetylcysteine. Do you use this? You have the experience?
I don't use.
Second thing about the role of stem cells in this case of the PUK management.
So, okay, first easier thing, the stem cell in dry eye or in this PUK at the moment not a good idea, but I have been thinking about an idea for PUK or Moran's using the mesenchymal cells. However, I have not used because they are not that easily available. For dry eye or the filamentary keratitis, I think the best in my hand works is topical steroids, lubricant, and a Prose lens or a Boston scleral lens. And we have now that Boston scleral lens made in India in LVP available to all of us. Very helpful because it's filled with the liquid.
Any suggestion for the lubricating, especially any lubrication in this for?
Whichever you can find which is preservative free and patient tolerates well.
Okay. Thank you.
Thank you. Yes, doctor. Doctor asked if do we need to use any systemic steroids before patient is taken up for cataract surgery. No, if the patient's condition is controlled without any medication and stable for at least 3 months, I don't start any systemic treatment or topical treatment just because I am doing cataract surgery. If somebody is already on a maintenance dose of immunomodulation, I will not increase, I'll just continue to use and do the surgery. And if I find that more than usual inflammation on day 1, then I will increase the doses. Otherwise, not required for any of the inflammatory diseases. Thank you.